Hi, in this video we will be discussing about penicillins. It comes under the beta-lactam antibiotics. The beta-lactam antibiotics are named so because of their common beta-lactam ring. These include penicillins, cephalosporins, carbapenems, and monobactams. And here you can see the chemical structure of these antibiotics, and the highlighted ones are the beta-lactam ring that is common in all of these antibiotics. Now let's discuss a little more about the structure of penicillins. All penicillins consist of a beta-lactam ring and a thiazolidine ring. There is also a side chain, that is the R group, which is unique for each antibiotic. For example, for penicillin G, which is a natural penicillin, it has a benzyl side chain at its R group. This side chain can be split off by an enzyme called amidase, and then other side chains can then be attached to it. This way, different semisynthetic penicillins are made. An important point to note here is that the structural integrity of beta-lactam ring is essential for its antibacterial activity. Based on their antimicrobial activity, penicillins are divided into the following categories. So we've got narrow-spectrum penicillins, narrow-spectrum penicillinase resistant penicillins, and extended-spectrum penicillins. The narrow-spectrum penicillins include Penicillin G, also known as benzyl penicillin, and Penicillin V, which is also known as phenoxymethylpenicillin. Then we have nafcillin, oxacillin, and flucloxacillin, which comes under the narrow-spectrum penicillinase resistant penicillins. And finally, we have extended-spectrum penicillins, which includes aminopenicillins, which has amoxicillin and ampicillin. We've got carboxypenicillins, which has carbenicillin, and finally uridopenicillins, which includes piperacillin. Now let's look at the pharmacokinetics. Penicillins vary in their oral absorption as it is acid labile, that is, it is destroyed by the gastric acid. It is very little metabolized because of its rapid excretion. Penicillins are widely distributed in body fluids, passing into joints, into pleural and pericardial cavities, into bile, saliva, and milk. Penicillins do not cross blood-brain barrier unless the meninges are inflamed, in which case they reach a therapeutic concentration in the CSF enough to kill the susceptible organisms. And finally, penicillins are excreted from kidneys via glomerular filtration and tubular secretion. The plasma half-life of most penicillins vary from 30 minutes to 1 hour. Now, the mechanism of action. I won't be going too much in detail as I've already discussed it in my previous video, but I'll just quickly go through the major points. The penicillins are bactericidal drugs. It binds to the penicillin binding proteins in the bacterial cytoplasmic membrane, thus inhibits transpeptidation reaction. This prevents the cross-linking of linear peptidoglycan chain, thus inhibits cell wall synthesis. This further causes osmotic damage, leading to rupture and cell death. Now we will go through each of these drugs in detail. The first we have is Penicillin G. It is a natural penicillin. It is also known as benzyl penicillin and can be administered intravenous or intramuscular. Penicillin G are available in various salt formulations. We've got procaine penicillin and benzathine penicillin. Both can be administered only intramuscularly. These forms of penicillin G have long plasma half-lives as the drug is released very slowly into the bloodstream. Then moving on to antibacterial spectrum, as we have seen it earlier, it comes under the narrow spectrum penicillin. Because mostly penicillin G are used against gram-positive organisms. However, the Staphylococcus aureus, which was originally sensitive, has now acquired resistance to penicillin G. They're also used for gram-negative cocci, example like Neisseria species, except the penicillinase producing Neisseria, and spirochetes, example Treponema pallidum, and they are not sensitive to gram-negative bacilli. Now coming to pharmacokinetics, they have poor oral absorption as it is acid labile, hence it must be given by injections, and they are beta-lactamase sensitive. Then coming to clinical use, these are drug of choice for treatment of syphilis. They're used to treat meningitis caused by meningococci, are also used for infections caused by sensitive strains of streptococci, including pneumococci, hence used to treat pharyngitis and otitis media. Now we have Penicillin V, which is also known as phenoxymethylpenicillin. Its antibacterial spectrum is similar to Penicillin G, hence it also comes under the narrow spectrum penicillins. The only difference is that it is acid stable, hence can be given orally. However, it is less potent. We have narrow-spectrum penicillinase resistant penicillins. They are used for infections caused by specifically penicillinase-producing staphylococci. These drugs have bulky side chain attached to the beta-lactam ring. This protects the ring from beta-lactamases and hence makes the drug resistant to inactivation by these enzymes. Its clinical use is for treatment of mild to moderate localized staphylococcal infections. Now we have extended spectrum penicillins. They are named so because they have greater spectrum of activity against gram-negative bacteria. However, they remain susceptible to beta-lactamases. Now let's go through the ampicillin and amoxycillin. Ampicillin are active against all organisms sensitive to penicillin G, plus the gram-negative bacilli, Haemophilus influenzae, E. coli, Proteus, Shigella, and Listeria monocytogenes. Amoxicillin has also similar antibacterial spectrum to ampicillin. With ampicillin, oral absorption is incomplete, whereas oral absorption is better with amoxicillin. Diarrhea is a common adverse effect with ampicillin because it is incompletely absorbed and can cause irritation to the intestinal mucosa, whereas there is lower incidences of diarrhea with amoxicillin. Food interferes with oral absorption with ampicillin, whereas food does not interfere with absorption with amoxicillin. Ampicillin is used to treat urinary tract infections and respiratory tract infections, whereas amoxicillin are mainly used to treat otitis media, sinusitis, and lower respiratory tract infections. Then, with piperacillin, they are active against many gram-positive and gram-negative bacteria, including Pseudomonas aeruginosa and Klebsiella pneumoniae. However, they still remain susceptible to penicillinases. Piperacillin is combined with tazobactam, which is a beta-lactamase inhibitor, and it is used to treat intra-abdominal, skin and soft tissue infections, pneumonia, and complicated urinary tract infections. Now, coming to adverse effects, penicillins are very notorious for causing hypersensitivity reactions. They are caused by the degradation products of penicillin, which combine with the host protein and become antigenic. This may result in the production of antibodies or activation of T cells. There's a wide range of type 1 to type 4 hypersensitivity reactions that can occur with penicillins. Rash is a very common symptom. There can also be anaphylaxis, and in about 5 to 10% of people with a history of penicillin reaction have an allergic response when given penicillin again. And with cross-allergenicity with cephalosporins, it is less than 2%. With carbapenems, it is less than 1%. And there is no cross-allergenicity with monobactams. And the other very common adverse effect with penicillins are the gastrointestinal disturbances, which includes nausea, vomiting. And sometimes when given orally, penicillins, particularly the broad-spectrum ones, can alter the normal flora in the gut. This can result in pseudomembranous colitis caused by Clostridium difficile. And this concludes our discussion about penicillins for today. Thank you.